All right, wonderful. So we're really hoping that you can help contribute to our paper on these consensus guidelines. So we are hoping that everybody can use the questions and then help us get some more data for our paper. And we have a star-studded lineup of people who've been contributing to this paper. There are a number of people who've been doing a lot of work who aren't here. So we'll acknowledge Moanne and Shalini while I remember. But essentially, this is a group of people who've been trying very hard to create a consensus guideline. Is the app description working? Yeah. Okay. So don't answer the questions yet. We want you to answer them as we ask them through the presentation. Okay, so my name's Hannah Seymour. I'm a geriatrician from Perth, Western Australia. And between us all, we have one conflict of interest to declare. So, why have we spent our spare time creating a consensus guideline on DOACs? So, there is an obvious problem between people who come in on blood thinning agents and needing surgery. There is a risk-benefit that is not clear. That risk is between needing lots of blood and having clots. We know that there is lots of variability. And what doesn't work is a junior doctor ringing, often an inexperienced junior doctor, late at night, ringing another junior doctor who's also quite often inexperienced and hasn't actually met the patient, and asking advice about what you should do. And all you get is a whole load of people giving different opinions on different occasions, which leads to variability. And that, I think, is the situation. The only data that's available are small observational studies that haven't given us an answer. So it's also an increasing problem, and we saw that in another presentation. So the percentage of people with a hip fracture who are taking DOACs is going up year on year, and this is just my hospital, but this is happening around the world as DOAC use is increasing because they're good drugs and they prevent people having strokes. So there isn't any clear guidance on emergency care, which leads to variation in practice, people trying lots of different things, some people waiting longer preoperatively, people debating what sort of anaesthetic to give and when to restart DOACs. And if you ask different groups of doctors, they prefer different guidelines. So again, there is no multidisciplinary guideline that says what to do. So we've had a working group. So Rebecca Mitchell, who's on the panel and about to give the first talk, Anna Claudia Tonelli, who's not here, Flavia, who again is about to contribute to this presentation, along with Amy Mayer, Moanne, who isn't able to be here, and Seth Tarrant is in his place. So we're going to keep moving because we've only got an hour and we want to get through all of the information.
Thanks, Hannah. I'm Rebecca Mitchell. I'm the epidemiologist on our team. And what we decided to do is, because there was all these conflicting advice around hip treatment of patients on DOACs with a hip fracture, we decided to put together a systematic review to see what had been happening in the area. So we're looking at the impact of DOACs on hip fracture outcomes for patients. We started the review back in 2021. We found 21 articles. 12 of the studies didn't identify that hip fracture patients had a longer time to surgery than patients not on DOACs. And where reported, we found that DOAC users did not have increased mortality, blood loss, transfusion rates, complications, or rates of stroke or readmissions compared to non-DOAC users. As well as looking at the results from the systematic review, we also looked at a range of guidelines, and these were just 4 that we looked at, but there's been quite a few published that have some conflicting advice around what to do with hip fracture patients on DOACs. So we thought, well, we need to get some consensus from the experts about what we should do for treatment with patients on DOACs. So we started this at the last FFN back in Melbourne last year, and we ran a workshop with conference delegates who helped us frame some questions that we should be asking around care for treatment of patients on DOACs. And then we sought to run a 2-round modified Delphi study to gain consensus from experts about what treatment should be provided. So our expert panellists were drawn from a range of different professional networks, including this network, registries, hip fracture registries, along with professional associations and meetings that had been run internationally. We had 90 identified expert panellists, and then we had an extra 21 identified through snowball sampling. We had 61 panellists who responded to our first round 1 question, so we had a response rate of 68%. And then for round 2, we had 44 respondents of the 61, so we had a 72% response rate, which wasn't too bad. Our expert panellists, a lot came from North America, some from Australia. I'm pretty sure there's a few from the UK in there, just very lightly shaded, and we had quite a few from Brazil, which was great. In terms of frequency, we had quite a few orthopaedic surgeons, geriatricians, anaesthesiologists, etc., who were responding to the survey. We contacted all the panellists via email. We ran 2 rounds of the survey earlier this year, just using RedCap. Each survey ran for 4 to 5 weeks, and all the responses were anonymous. And the areas that we asked about were peripheral nerve blocks, time to surgery after last DOAC, time to general or spinal anaesthesia from last DOAC, and time to recommence DOAC. So we're trying to get consensus on treatment in those areas. In terms of the modified Delphi Round 1 survey, we asked in terms of, for example, time to surgery, we asked a range of different times, and people got to vote for different times when they thought time to surgery should occur. And in the round 2, we provided a same question, and the respondents, our panellists, received information on how the round 1 responses were rated. They could then rate again and provide any rationale or comments that they wanted to. We decided our consensus levels a priori, so 70% agreement was going to be high consensus, moderate consensus 50 to 69%, and we decided we needed at least moderate or preferably high consensus among our panellists. And lastly, as well as doing the modified Delphi study, I don't know, many of you may know or be aware that Wiki Guidelines are doing clinical guidelines now. And they're quite interested in our consensus statement being a part of their Wiki Guidelines approach. So as well as doing our earlier systematic review, we've done a few other reviews to update to the latest literature. And one part of the Wiki approach is we have to consider alternative hypotheses and disagreements and potential impact on low-resourced countries, which we have done in what we have developed. So that's one of our next phases to do. So now I'll hand over to Amy, who will take you through some of the results.
Okay, hi, I'm Amy Mayer. I'm a consultant anaesthetist from the UK. Right, can everyone get their phones out and go to your home screen, because this is part of the interactive bit. We're going to get you guys voting. But don't vote now, only vote when I tell you to, okay? So, the first question we asked was about giving peripheral nerve blocks in patients, our hip fracture patients that have taken their DOAC, they've fallen, they need a block for analgesia. How long after they've had their DOAC can we give a block? And you can see these are the results from all of our panellists. And the results were very similar for the factor Xa and the direct thrombin inhibitors, that people were really favouring early blocks in these patients. And we had high consensus for this. So there was high consensus among our panellists that a peripheral nerve block could be cited on presentation. So your patient comes into the emergency department, you do not wait. You can put in that nerve block straight away, okay? The risk is low. And this makes sense. We've had some great presentations today about delirium, and we know that opiates, which is the alternative really for this really, really painful condition of a broken leg, is just really poor. The opiates don't work. They have high rates of delirium and all sorts of other horrible complications. And actually, the nerve blocks that we place for hip fractures, things like the fascia iliaca, femoral nerve blocks, these are really superficial blocks in relation to, deep lumbar plexus blocks. And so they're low risk. And the risk is reduced further by, the use of ultrasound, the atraumatic needles. And it's not just us that think that you can put peripheral nerve blocks in these patients straight away. Other societies are saying, well, yeah, the rules we have for neuraxial techniques, and by that I mean spinals and epidurals, those rules are far too restrictive, and putting peripheral nerve blocks is okay, and we can do that straight away on patients that are taking DOACs. But as with everything, this needs to be an individual patient risk assessment. So time to vote on question 1, okay, and this is on timing of peripheral nerve blocks. Our recommendation to you all is that peripheral nerve blocks can be performed on presentation when patients come into the ED, even though they're taking a DOAC. Do you agree with this statement? You can vote yes, no, or not sure. We'll give you a few seconds to decide on that. So it doesn't matter when that patient's popped that pill. They fall, they break the hip, they're in agony. They need a nerve block. We're saying you can do that. So, wow, that's brilliant. 100%. Yeah, I like that. Good on you guys. Okay. So the next thing I'm going to talk about is general anesthesia, not spinal anesthesia, which I know is controversial, and I'm going to come to that, but how long can you wait before giving a general anesthetic after that patient has taken their DOAC? Don't vote yet. These are the results, okay, from our panelists. So you can see this trend towards early surgery, and yeah, we had that with high consensus that general anesthesia can be given to these patients within 36 hours of them taking that pill. And actually, there was moderate consensus. So 2/3 of the panelists thought you could actually do it within 24 hours of last dose. And this is assuming normal renal function, okay? And this kind of makes sense because traditionally in the UK, we did a lot of spinal anesthetics. We've heard from people today that saying, the anaesthetists want to do spinal anesthetics. But are spinal anesthetics better than general anesthetics? And the research out there is no, they're not. There's no difference in mortality. There's actually no difference in morbidity. Things like delirium, things like time to ambulation, there is no difference. The thing that saves patients is getting them to theatre. Expediting surgery, that is what saves them. I can see, the surgeons nodding in the room going, yeah, we need to get these patients to theatre. Certainly in my trust, our audit data shows that if our patients, any patients, wait for longer than 36 hours, their mortality goes up by 5%, up by 5%. The increased risk of pneumonias, these pathologies of recumbency, double. Getting patients to theatre is what matters. So, this is our recommendation. So you can give a general anesthetic to a patient taking a DOAC that needs hip fracture surgery within 36 hours. And I'd like you to vote. This is the second time for you to vote, guys. So do you agree with this statement? Yes, no, not so sure. Patient pops their DOAC, breaks their hip, and with 36 hours, you can give them a general anesthetic. What do you guys think? Wow, okay. Yeah, that's really good. Okay, so I'm going to move on. So this is the controversial bit, okay, and this is the results from our panelists. How long should a team wait before they give a spinal anesthetic? And for the anaesthetists among us, then the risk or the worry is this risk of vertebral canal hematoma. So you're taking a DOAC, you're putting in a spinal anesthetic, you're going to cause bleeding around the spine, which is going to lead to permanent neurological injury. That's the concern. And unfortunately, this was the results so far, that there was a bit of a split. People really couldn't decide what to do. And so far, we have no consensus about when to give a spinal anesthetic. And as a consultant anaesthetist who specialises in trauma, and my speciality is regional anaesthesia, this really has kind of made me quite sad, because since 2017 in the UK, we have been putting spinal anaesthetics in patients on DOACs after 24 hours, just 24 hours. And indeed, 71% of our patients in our institution get spinals 24 hours after they've taken that last DOAC. Not 24 hours after they've admitted, 24 hours after they've taken that DOAC, okay? And certainly since 2020, the Association of Great Britain and Ireland, this has been national guidance in the UK, that 24 hours you can put a spinal in. It is okay. It is accepted practice to do so. And in the next few slides, I'm going to reassure you why. After 2 half-lives, and for most of the factor Xa inhibitors, even in the elderly population, the data will show you that the half-lives is at longest 12 hours. I mean, apixaban's only 9 hours. But, you know, the longest is about 12 hours. And so in 24 hours, after 2 half-lives, 75% of that drug has gone. There is only 25% of that drug circulating, okay? And it is really common for us anaesthetists to put spinal anaesthetics in patients that are still slightly anticoagulated. Again, national guidance. So this national guidance in the UK, INR of less than 1.5. That's not normal. 1 is normal. So less than 1.5, you can put a spinal in. Since 2009, so the Scottish Intercollegiate Guideline Network, they were way ahead of us. So in 2009, they were saying, if you've got a patient on clopidogrel, any single antiplatelet, even clopidogrel, don't stop it, put a spinal in. It's fine. The risk is tiny. We are used to putting in spinal anaesthetics in patients that are still a little bit anticoagulated, okay? The risk is not vertebral canal hematoma. The risk is VTE. These patients are taking DOACs because they are prothrombotic. They have a inherent prothrombotic state. They have a trauma. That trauma institutes an even larger prothrombotic state. The risk is VTE, not this tiny risk of vertebral canal hematoma. But how can I reassure you? How can I prove to you? Well, we can't, because the data's just not out there because the risk is so tiny. There was this great study published in the BJA by Oster, which I just loved, and they put in wide bore, so big chunky needles, TUI needles, epidurals for patients undergoing vascular procedures, and they were all on clopidogrel, which was not stopped. 217 of them were on aspirin, so dual antiplatelet, and then 238 of them got IV heparin, which was not reversed at the end of the procedure, and none of them got vertebral canal hematomas. But I accept it's a small study, so let's scale it up. Let's get better evidence. And that comes from the Royal College of Anaesthetists in the UK. So they spent a year looking at the complications of every single neuroaxial block done in the UK, okay? Spinals, epidurals, what happened to these patients? There was only 6 vertebral canal hematomas, all of them in epidurals, none in spinals. If I had to do a study to prove to you guys that spinals in patients that are taking DOACs after 24 hours is safe, it would take me decades. And that's such a shame, because we know there are patients out there that could do with a spinal, patients that have got chest infections, patients that have got difficult airways. These are the ones that need spinals, and they're having to wait for their surgery, and that's what's killing them, waiting. So I want to attempt to quantify, I want to attempt to give you some numbers to hang your hat on to show that this is safe. So the NAP3 study showed an instance of 6 vertebral canal hematomas in over 707,000 central neuroaxial blocks. Based on data from case reports, because it has to be case reports, because vertebral canal hematomas are so rare, that the statistical data shows that your risk is increased by 15 times, okay, if you are fully anticoagulated. So we can say, doing the maths and applying it to the NAP3 data, that your risk is 1 in 7,860 of a vertebral canal hematoma if you put an epidural, wide-bore epidural, in a fully anticoagulated patient. If you apply that data, so that statistic, to the UK, well, England, Wales, and Northern Ireland, NHFD data of 500,000 hip fracture patients in the last 10 years, in a decade, we would only expect to see 64 vertebral canal hematomas if we put in epidurals in fully anticoagulated patients, which we don't do. We put in spinals, which, as you've seen, the risk is negligible, and into patients that only have 25% of that drug remaining. And it's not even then that the vertebral canal hematoma is the issue, okay? It's the fact that it's unrecognized and then untreated. That's what the problem is. So if you are concerned, then vigilance is key. Diagnose this tiny risk, rare thing, and get it treated, because having it recognized promptly and treated is quite successful, okay? So the risk is absolutely tiny. So, after all that, what do you guys think? Okay, patient takes their DOAC, You can vote now. How long should you wait after taking a DOAC? Okay? Less than 24 hours? Like we do in the UK, at 24 hours, 24 to 36 hours, 2 half-lives, 75% of that drug has gone. 36 to 48 hours, or over 48 hours, which is really the elective guidance. Or you're really not sure. I'd love to know your opinions on this. Wow, 78.9% of you think 24 to 36 hours. Okay, I'm glad I've managed to convince you about that, because that's certainly what we're doing in the UK, and it's certainly very, very successful. So, talking about anaesthesia, just a little bit of summary from me before we move on. So, give your patients nerve blocks when they come in. Don't give them loads of opiates, give them a good working nerve block. As soon as they come in, it doesn't matter when they've taken that DOAC. Do surgery within 36 hours, and if you still can't convince your colleagues, please give them my email address. I will convince them to do a spinal anaesthetic at 24 hours. But if you really can't convince them, just get them to do a general anaesthetic, okay? And so far, but you guys have probably helped to change that. We hadn't reached the level of consensus of spinal anaesthesia, but certainly in the UK, like I say, 24 hours is fine. And the decision can always be discussed with the patient, and you've got to treat every patient as an individual. If they've got a chest infection, if they've got a difficult airway, if they've got bad renal function, speak to them about the risk. You've got some numbers now to give them and to explain to them how rare these complications are. And I just hope you get these patients to theatre, get them done quickly, and save lives. Thank you very much. I'm going to pass on to Seth.
Yeah, thanks, Amy, for your enthusiasm and passion for the topic. That's how I got started with this topic, because I was passionate about my patients not being neglected. So my name's Seth. I'm an orthopaedic surgeon from Australia. My interest is in polytrauma, pelvis, acetabulum, periprosthetics, and of course proximal femurs. So in regards to the consensus, I'll just go through the questions and try to interpret what the respondees thought. So, question 4. For which type of hip fracture should a surgical team not interrupt DOAC use? In other words, continue the DOAC. The majority of our respondents said none. So none, not interrupting, which is another word for saying stop it all. So I suppose it's always a balance of probabilities. The majority of patients on DOACs are for atrial fibrillation. So the chance of them having a thromboembolic stroke versus having bleeding out or having cardiac complications from lack of preload, the respondents thought it was worthwhile stopping agents. The second biggest bar was we really didn't know. We didn't know whether to stop them or continue them. The balance of probabilities is not well borne out in the literature. In regards to when we broke up by surgical procedure, the clinicians were happy continuing the DOAC for cannulated screws, which makes perfect sense. Cannulated screws is either percutaneous or through about a 4 or 5 centimetre incision. The next operation where clinicians were happy continuing the DOAC with a trochanteric femoral nail. Once again, femoral nailing, easy, little incisions, we hope, but they can also become very complex. Then followed by the dynamic hip screw, obviously a 92mm implant, followed by the hemi and the total, which were equivalent. So surgeons were happy continuing for the smaller procedures, but as we got to bigger incisions and more operative times, clinicians thought it would be best to stop the agents. The next question, which is another way of looking at some sort of theme. For which types of hip surgery should a surgical team delay surgery? So this was 48 or 72 hours, whatever the surgeon or the clinician thought was appropriate, and what delay meant. Thankfully, the vast majority said none. There is no type of hip fracture surgery we should stop for. And then we see the inverse of the previous slide. The majority then for the operation thought that maybe we should stop the most for total hips, where we ream the pelvis, followed by hemiarthroplasty, where there's a decent approach, and then followed by the DHS, which of course is a 15cm incision, followed by the femoral nail and cannulated screws. Very few thought we should wait for surgery. So this all sort of made perfect sense. How long from the last dose should surgery be delayed? So this is the real crux, and we do split into factor 10A inhibitors and also direct thrombin inhibitors, mainly due to the excretion. They have different properties. There was no delay at all, and the under 12-hour category is really a surrogate marker for cracking on, to use a colloquialism. The majority of the respondees thought either within 12 hours or 12 to 24 hours, and even 12 to 24 hours is almost immediate surgery. after the last dose. We know, that the time between dosage and emergency presentation is probably about a mean of 6 hours. ED time is about 6 to 8 hours, let alone then booking them to the operating room and trying to assemble a surgical team depending on the time of day and also what else is on the plate for the orthopaedic team. So between the under 12 and 12 to 24 hours, that to me is immediate surgery, which is excellent. We then see slightly different curves. Looking at the direct thrombin inhibitors, there's less of a tail off, whilst the 10A inhibitors really drops off. And that, to my mind, for me trying to interpret it, may be due to the excretion. Factor Xa inhibitors are classically hepatic excretion, and very few of our patients have bad liver dysfunction. However, direct thrombin inhibitors, dabigatran, is mostly renally excreted, and a lot of our patients do have element of chronic kidney disease. When we went for the classic dichotomous cutoff, this magical 36 or 24 or 48 hours, when we looked at both factor 10As and direct thrombin inhibitors, we did reach consensus that doing surgery within 36 hours of the last DOAC dose is reasonable. When we tried to decrease that dichotomy within 24 hours, we had less consensus. So I think moving forward, 36 hours is a nice time frame, which definitely fits in with the best practice tariff for the UK, and also the ethos of the day of surgery or the day after. And we sort of moved away from the 48 hours, which can really be the day of surgery, day after, or the day after that. So in terms of a conclusion for timing of surgery, really from the literature, there's no evidence to indicate surgery for DOACs could reasonably be delayed, including for different types of hip fracture surgery. And the sort of consensus has led us to that. The literature is quite dirty for this topic. There's no randomised controlled trials. A lot of them are retrospective. There's only 2 studies over 100 patients with DOACs in the literature. One was from Salzburg this year and the other an Australian group published a couple of years ago. And a lot of them compare apples and oranges, comparing patients taking DOACs versus those who aren't on DOACs. That to me doesn't make any sense. It doesn't matter. It should all be about looking within the DOAC group themselves and which patients do better or worse. We know from the studies that do that patients who have higher factor 10A levels and also patients who have earlier surgery do have a higher allergenic transfusion risk, but there's very little difference between adverse events and also mortality. So hopefully this inspires people to make sure that they push their departments to try to get these patients done as soon as possible, or at least, excite people to maybe have high levels of evidence, randomised, so we can try to figure out where the truth is. Thanks a lot.
Hi everyone, good evening. My name is Flavia Borges. I'm from McMaster University, Canada, and I'll take the task to finish the discussion around timing of surgery and also about recommencing DOACs. I know I'm the barrier between you and the reception, so I'll try to be quick and hope we can enjoy our evening. So I would like to talk a little bit about the HIPATEC trial because it's a big trial with almost 3,000 patients looking into timing of surgery, and we randomize patients for accelerated surgery, which means surgery within 6 hours from orthodagnosis compared with usual care. That standard timing for surgery in the study was 24 hours. And although we comment during the day that there was no difference in terms of all-cause mortality and major perioperative complications at 90 days, there were improvement on many patient-important outcomes with accelerated surgery. Patients in the accelerated care arm, they had less delirium, 28% relative risk reduction in delirium, decrease in urinary tract infection, early mobilization, better pain outcomes, and early hospital discharge. However, patients we are discussing today were excluded from the trial. We did not include patients with hip fractures on DOACs in the first trial. So although we know the benefits in terms of improving and expediting surgery, we don't know the data from the safety perspective in terms of bleeding in this population. I'm happy to say we are advancing knowledge, and now we are allowed to recruit in HIPATEC 2 trial that's ongoing in 40 centers. We are doing randomized randomization of hip fracture patients with elevated cardiovascular risk to go to surgery. And in the second trial, we are randomizing patients on DOACs, and we have a subgroup analysis to try to have the first RCT on this topic. So we would like to thank our colleagues from the UK because they are advanced knowledge as we don't have specific RCTs, but as Amy was saying, they are now expediting on their guidelines the surgical times, allowing spinal anesthesia within 24 hours. And I think the guidelines, they gave a lot of consideration in terms of balancing risks and benefits of expediting surgery. And from their recommendations, they mentioned that the risk of delaying surgery and the thromboembolism usually greatly outweigh the risk of vertebral canal hematoma and also the perioperative bleeding. So in regards of timing of surgery, we really need to balance the approach considering the patient individual and competing risks. So we know that the fracture per se causes bleeding. We know that if we delay too much surgery, the patient will have local bleeding. So that's also a concern to delay surgery, but also we have to balance with the risk of intraoperative and postoperative bleeding. Usually when I talk to my colleagues from surgery, they say we can control bleeding during surgery. So the issue is more the anesthesia as opposed to be this surgical intraoperative bleeding, the concern. We know that we have to balance the potential benefits that the hip attack trial show, but also we have certain populations that we will have to adapt our recommendations in terms of patients presenting with anemia and low hemoglobin, patients with higher cardiovascular risk, depending on kidney function, because we know that the DOACs have different creatinine clearance depending on their half-life, and also considering the elimination half-life. But as we have commented here, if we wait at least 2 half-lives from the last dose up until surgery, most patients will be safe to proceed to the OR, and we will have, therefore, less than 25% circulating the active drug if we propose the surgery within 36 hours, as Seth just presented to us. So now we can go to the poll, so you can grab your cell phones and vote. Our question is, if you would perform hip fracture surgery for patients who are taking a DOAC within 36 hours from the last dose, yes, no, or you are unsure. Okay, so you can put the poll up. Okay, so I guess I convinced everyone. Thank you. So let's go to our last topic. And here the question is about recommencing DOACs. So for patients that are on anticoagulation, when should we recommence a DOAC after the surgical procedure happened, considering that you had a regular intraoperative with no major bleeding and a good hemoglobin control? So here is the first round, and you can see that the results were split between 12, 24, and 48 hours. And when we performed the second round, the consensus was splitting between 24, 36, and 48 hours. So based on the results that I just showed you, I'm glad that we have the possibility to achieve high consensus with greater than 80% of the participants responding that we could reasonably recommend a DOAC within 48 hours from the surgical procedure, and a moderate consensus also to recommend a DOAC between 24 and 36 hours. So this aligns with the literature. This is the NHS guidelines, where they do recommend that after a femur fracture, it's very reasonable to restart a DOAC within 48 hours post-operatively. Of course, you're going to consider wound topical issues and stop the prophylactic low molecular weight heparin, and it will depend on the creatinine clearance. But overall, within 48 hours would be safe to recommend a DOAC. And they brought up the results from the PAUSE trial that Dr. Duquetis performed, was published in the JAMA in 2019. This study proposed a strategy to stop and recommends DOACs around timing of surgery. This was focused in elective surgery population, so we don't have any specific large study for hip fracture patients, but a lot of the recommendations adapt the proposal from the PAUSE study that also proposed that for high-risk patients undergoing surgery, we usually recommend a DOAC on postoperative day 2, which would be around 48 hours after surgery, aligning with our consensus. And in their study, when they look into 30-day outcomes, of course, here was more specifically for elective surgery, there was lower rate of bleeding and lower rate of thromboembolic events, mostly stroke, looking into 30 days after surgery, regardless the type of DOACs that they were looking into. So it seems a safe strategy. And also aligning with our results, this is the American College of Chest Physician consensus, the last one published last year. And they also suggest that in patients taking DOACs and undergoing surgery, there's no comment in this guideline specifically on hip fracture, but undergoing elective surgical procedures, they suggest to resume a DOAC greater than 24 hours. So they should not be starting earlier than 24 hours. And the major issue is that those drugs, they have a very rapid onset of action. In 1 or 3 hours after the patient takes the pill, they are fully anticoagulated. Of course, any recommendation needs to be adapted to a specific patient population, so we have to consider individual patients' risk and what happened during the surgery, if the patient required transfusion, the postoperative hemoglobin, the risk of local complications, but also have a high consideration for patients on a higher thromboembolic risk. As it was mentioned here, those patients were on DOACs for a reason, so if they had a recent stroke, particularly atrial fibrillation with a stroke within the last 3 months, you want to recommend as soon as possible because they're on a higher risk of having a postoperative stroke. And also if they had a previous deep venous thrombosis or thromboembolism, like a pulmonary embolism within the last 30 days more specifically, then you also have a patient in a very high risk category to have a recurrent event, and you want to start an anticoagulation as soon as possible. So now it's your moment to participate. We're going to bring our second pool. That's if you would recommend a DOAC, considering that there was no major hemoglobin drop and regular bleeding loss during the surgery within 48 hours of your hip fracture surgery. Yes, no, or unsure. I think you can bring up the pool. Okay, very nice. So I think I'll call Hannah to come and just to wrap up, and then we'll have the panel open for questions.
Thank you. So we can all breathe now because we've got through the questions. Annetta wanted some volunteers to have less time in the workshops. There's only 60 minutes in this workshop. So I apologise for us getting going because we didn't want to get to the end and not have time. So my co-presenters have done an amazing job and we've got through. So now we wanted to have a bit of discussion about, will this actually help you? And is there anything that we can do to help reduce the variation in waiting for hip fracture surgery, or for any comments that people want to make? The aim is to get this published fairly quickly. I think we're pretty ready to go and get that out there, which should help at least reduce some of the variation that we know is still happening without limiting. So we worded these quite carefully so that they didn't limit anybody and didn't put any restrictions in places that are already have experience in expediting surgery. So can you just go back to the slides? I think it doesn't really matter what we show now, but anyway, so we'd be really interested. Erica's got the microphone. Ben has a microphone. Comments, feedback. What can we do with these guidelines that would help? Will they be at all useful, or have we just wasted the last month of our, last year of our emailing backwards and forwards quite regularly? Pardon? Yeah, oh, there you go.
I'm not quite sure. I'm working in a country now where there is no FFN, and we are not really good at pulling together. So people should know about this guideline, and I'm not sure how you would do that. I don't know. Publish it in, will it be published in some sort of international paper
Yes,
or
the
something?
aim is to publish it in a journal. I think the aim of things like these, from my thought process, is that there are people who medico-legally are quite conservative, and we know in Australia there are a lot of people waiting more than 48 hours for hip fracture surgery because the anaesthetists in particular are quite risk-averse. And at least if there is a guideline that says that this is a reasonable approach, there's something to point to. You then will always need more locally specific guidelines. So we'll have a locally specific guideline for us. But it would be good to know if we think that this will help reduce variation. Celia.
Thanks. Yeah, I think it's really impressive, and I'm pleased that what I'm doing is kind of what you're saying I should be doing, so that's helpful. When you come to publish it, just in terms of the last comment that was made, I mean, maybe it's helpful to have an A4 page within that publication that's a little flow chart that everybody can print out and stick on the theatre wall or the, where the trauma meeting happens, etc. And I mean, potentially, if you make that available in Word format, then people can translate that into different languages. That might be an idea. Just
Yeah,
a
that's
thought.
a really good idea. We can easily do that.
Great work, all of you, and great that you made this review, which will be internationally published, I'm sure. And now we also know each other's opinions about this. But how to stand on better ground, on evidence-based ground. So let me ask you, what would be your favorite RCT that we could use for this area clinically looking forward? What are we going to
As in terms of an RCT design, it would essentially be hip attack-esque. You know, I've got hip attack 2 currently running.
I know, but that will not answer that one. What
Well,
would be
it would answer in terms of timing of whether there's any difference between timing within the cohort on DOACs, whether there is any real increase to allogenic transfusion or increased serious adverse events or increased perioperative ischemic
as
events.
a subgroup analysis? So what would be your favorite RCT on this? Would that be national studies or an FFN as made study with multi-centers having patient operated within 36 hours, independent on type of DOAC, but not in an epidural, maybe in the spinal, as you said, versus another group not being operated but delayed until plus 36 hours? Would that be a setup
So that's
that
really
will, that
Yeah,
will
I
be
think
useful in the clinic?
So that's a good question. Maybe we'll go down the panel.
Yeah, Flavia's better at...
Because I don't think 36 hours is what I would do, but Flavia, what would you do? If you were going to do an RCT that would help us answer this, because I think the problem is that we don't think that's likely to happen, what would you do?
Yeah, Flavia's much better. I do RCTs with Flavia.
Well, I would love to do that. I think the consensus is one step forward to see the acceptability of people to do that. Because as we were commenting in Hip Attack 2, we had, I think, a battle of more than 6 months with the REB to approve, and we kind of pushed through because of the UK guidelines. But REB was not saying it was safe to propose to expedite surgery on those patients. And when we go back to look into the literature is frail, is based mostly on observational studies. So I think the more we discuss, the better. I think this consensus publication will be a big step forward. and hopefully, more colleagues accept this strategy, even to put their patients in the study, because when you propose a trial, you need the sites recruiting and believing in the idea and willing to participate.
And going back to your question, at what level would you run this? With multi-centre, multinational, FFN, within hospitals? I suppose it depends on your powering, depends on what your outcome measure is. I sort of, Professor Costa's very impressive Wide 8 trial, we're powering to differences in infection, which is a rare outcome. I think for a study like this, you maybe put it to transfusion, which is pretty common. It's up to 50% in the cohort studies in the literature. So you could look for differences in transfusion rate as an outcome rather than mortality. Something that's still meaningful and still quite common.
Amy, did you want to add anything?
It's not an RCT as such, but what I'd like to see is people taking plasma levels for factor Xa inhibitors when these patients have their spinals. Because I think you'd probably find that the factor Xa plasma levels were higher than you think, yet these patients don't have the complications. And we can really give some numbers to what, that this is safe. People like to have it's a slightly moot point because a lot of centres, certainly we don't have the technology to monitor plasma Xa levels. But I think we're putting spinal anaesthetics in patients that are really quite anticoagulated, more so than we think, and it is actually okay.
We do lots of levels. Let's not go into levels. Jackie.
Oh, just a comment in terms of the trials. I don't know the RCT is going to be the answer for this question, but we've got a number of registries across the world. A number of them will do sprint audits every year. We could use that as an opportunity to build research into registries. And in terms of getting this published, I don't think you'll have an issue getting it published. But I think the issue is the anaesthetists. Oh, certainly in Australia, the issue is the anaesthetists in terms of not letting us crack on. The Association of Anaesthetists of Great Britain and Ireland seem to be the guidelines that even the Australian anaesthetists turn towards. If there was any way you could get them to endorse or for them to update their guidelines based on what you have come up with, I think that would be helpful. I don't know of any other guidelines that our anaesthetists tend to turn towards. They tend to be fairly respected. So just having that endorsement, I think, would help.
That's a really good point, actually. The data for the Association of Anaesthetists guidelines is mine. So what's run with this is what's run with the... So I advise the Association of Anaesthetists Working Party on hip fracture care on the point of DOACs. So if you go to the 2020 publication or just log on to the AAGBI national guidance and look under their guideline page, they do have a supplement, and it is a one-page Word document that you can print out and stick on your anaesthetic cupboard doors. I advised on that. So it's the same data for the same publication. It's just what we're doing in the UK. We're just trying to expand out everywhere and go, look, guys, it doesn't matter where you are, this works and it's okay. But yeah, if you look in the AAGBI national guidance, that supplement material is a Word document. You can print that out.
Rebecca, did you want to add anything? No. So look, actually, Jackie, that's a really good point. So what about us talking to the FFA? Is Anthony here? Because if every registry around the world that we know about and that are participating with us did a sprint audit that was with the same parameters, we know there's variation out there. So we actually know there's a lot of variation. There are places like Denmark, I think, where you operate pretty quickly. There are other places that are holding patients back for 48, 72 hours on the basis of DOACs. And what we've ended up with is a middle ground, which is not unhelpful. That helps move us forward. But if we did a sprint audit that was a bit coordinated between registries, we'd actually end up with way, way bigger numbers than anything that is out there in the literature at the moment, which might help us because of the inherent variation that we know is already existing. That would be something that is possible and maybe we could aim for. The other point about what we're trying to do is trying to keep something that we can keep living. So the wiki guidelines is an approach where you do keep updating it based on literature. We know there's a UK sprint audit coming out, or audit on DOACs. Amy, did you want to talk about that?
I won't talk much about that because Will's not here.
Okay.
But he's done a service evaluation in the north of England looking at the variation, found massive variation. But that's going to come out, that's going to be published in the UK, and very much is just going to report what is happening. Like I say, it's not mine, it's Will and the guys have done an amazing job by the sounds of it with big numbers of patients, but very much found what we found, that there was this variation and that we need to kind of reduce that to make sure that all patients everywhere are getting the best possible outcomes.
So I think what this takes us from is lots of variation to less than 36 hours variation, hopefully.
Some of you heard an hour ago Madsen talking about the obstacles we're fighting at Diakonhjemmet sykehus. I'm just a simple man running the ward, taking care of the hip fracture patients he's operating. And I am so tired of fighting windmills. So I would just like to say a massive thank you for the work you have done here, and I'm looking forward to the publishing of this article. Thank you.
Oh, thank you. Okay.
And I'd just like to sort of stick up for anaesthetists a little bit. Let's sort of talk about them being the major delays. We still have a lot of orthopaedic surgeons who delay because they are worried about blood loss and bleeding. And particularly the graph showed before that there's still a lot of concern regarding total hip arthroplasty and being on DOACs. And I think that'll be very hard to stamp out from a guideline. Changing orthopaedic surgicals' minds is, yeah.
To be fair to surgeons, if you're well enough for a total hip, based on Matt's discussion today, if you're well enough to have a total hip, you're probably the least of our worries in terms of waiting for surgery compared to many other patients who we look after. So agree, I think there's some debate about that, but I think for the majority of patients this really helps, and surgeons generally are not. It's the total hip replacements that they worry about the most, I think.
Thanks, Hannah. Owen Davies from Australia. You may want to shut me down given your comment, but based on previous discussions we've had elsewhere, was there a deliberate decision to avoid the question of using levels?
Yes, because they're not available and not many places have done them. So I can answer levels because we've measured levels at our hospital for the last 7 years. And I think that 50 is very, very definitely safe. It's probably too conservative. If I'm rewriting the guideline with levels, which I'm trying to get away from, it'll be 100, would be my thought process. There are a small group of patients, very, very small, less than 5%, who don't clear DOACs as we expect, and we can't work out why. But I don't think that should confuse people. I think the levels were a good approach for a place where we can get them within 30 minutes. In a high-volume hospital, it helped us at the time, but I don't think that's something that's been borne out in the literature or that we should be debating. But I'm more than happy to explain all of my thoughts about levels later.
Yeah, no, I agree with Hannah. We're in District General Hospital. We don't do levels, and that's why the whole 2 half-lives, 24-hour thing is so much more pragmatic. You would be, if we would start talking about levels, you would be alienating so many hospitals in the UK, and you would be putting so many patients at increased risk. The only thing I would say that we do in the UK is we measure thrombin time for dabigatran. So thrombin time is sensitive for dabigatran, and obviously dabigatran does have a reversal agent. Thrombin time is very easy to get in your labs. If your labs can measure fibrinogen degradation products, which most places can, I understand it's very, very cheap to add in the software or the hardware to be able to measure thrombin time. And if you get an abnormal thrombin time, there is an antidote for dabigatran, which is 80% renally metabolized. So these patients on dabigatran can wait for days, sometimes up to 5 days, if you don't reverse them. So actually in our trust, we do a thrombin time on patients on dabigatran. If it's normal, we proceed under GA or spinal. If it's abnormal, they get Praxbind and they get their operation that day.
So you'll notice that we've also kept this specific to people with normal renal function. So again, this is not going to solve every problem straight away. So, but in stepwise fashion, maybe we can then tackle that.
Can I ask why you'd want to use spinal rather than general anesthetic in a patient who's on a DOAC? What's the advantage? Yeah,
no, I completely agree with you. I mean, I am a regionalist and I love spinal anesthetics, and I am giving more and more GAs nowadays. Because, like you said, the data is just not there. However, you are always going to get patients that have the chest infections, the difficult airways where you really don't want to give a GA, and these patients do better with a spinal. But then, some places are going to have these patients delayed, and our point is don't delay. If you want to do a spinal at 24 hours on a patient that's got chest infection, you've often just got a window of opportunity. If you wait another 2 days, that patient's going to be worse.
Yeah.
So do a spinal, do it at 24 hours, that's fine. And it's patient-specific. With all of these guidance, you've got to look at what's best for that individual patient. And it usually is the difficult airways, the chest infections. They do better with spinals.
I think, that risk-benefit discussion with individual patients, medico-legally, covers everything anyway. And if you've got a specific patient who's so high risk that they really need a spinal, for me, I'm more than happy to go and have a conversation with their family about, look, actually, you're really going to benefit from a spinal. You're on this medication, it increases your risk, but overall, there is no evidence of what we should do, and on balance of the expertise that we have, we think this. And so long as that's all documented, we would proceed. So I think, it is really important to remember that there are very specific occasions where trials are never going to help us and guidance is never going to be there. And we just have to do what we think is the right thing in an informed way and in shared decision making. So I think that's always going to be there. Okay. So I think we've got a few minutes left, but I think we've covered nearly all of the things that we wanted to cover. Question? Okay.
Hi, I'm an anesthesiologist, so the second in the room at least. And I was just want to share the way that we think that we have solved the problem in my hospital, or trying to. Well, you assume that you may operate these patients in less than 48 hours. That's a fact. In our hospital it's 48, not 36. So you may think about bleeding and pro-thrombotic state. You are worried with the two. If you want to reverse, it's because you are not worried with the prothrombotic state. If you were, you would intervention these patients even if you think that they are a little bit anticoagulated. So we established the 48 hours goal. If the surgeon and the orthopedic and the anesthesiologist thinks that it's better to reverse some of the anticoagulant effect of DOACs, they may speak with the immunohemotherapy department and they may actively reverse it. And that's our way of solving things. So you just focus in the 48 hours and try to find a way of saying that you may not delay this procedure more than 48 hours because you think that this patient is anticoagulated and you are not afraid about reversing the anticoagulation. So if you want to do this, just do it, but don't delay it more than 48 hours. But like the rest of us, we are waiting for the guidelines so much.
So I think
we really want that guidelines to legitimate our...
Cool, well, we'll try. We haven't mentioned reversal at all in the guideline. We didn't ask about that because, again, there are no trials looking at that, or very few. There is discussion about a randomised trial of reversal agents for apixaban and rivaroxaban versus cracking on, I think, in Australia, and it would be great if that got up because that would help us as well. But again, I suspect they're going to be quite expensive and maybe are not required. So, it'd be interesting. I think the literature is going to continue to grow and hopefully we can keep these as living documents that do adapt as we get more and more information. And if there is any sort of registry sprint audit approach, that I think would really help us as well. So we might talk to the FFN special interest group on that. So really, thank you. Really thank you to our co-presenters. We really did work very hard to get this down to a time frame that was going to work. So thank you. And we know that we are standing between you and a glass of wine at the Oslo City Hall. So we're really happy. We'll be around all evening. Come and see us, come and talk to us. But we'll try and get this published as soon as we can. Just to acknowledge Rebecca's role in that. Rebecca is the best person to work with if you ever want to do a consensus guideline on anything and has kept us all honest and moving. Otherwise, we might not have made our timelines for this conference. So just wanted to specifically acknowledge Rebecca in all of that. But thank you all for coming and we'll use your contributions in the guideline.